and we include as much of what she can do, you know, and minimize what she can't do. So you can see that there are lots of options for her. She worked very closely with our nutrition team to come up with recipes and where to go for restaurants should she want to eat out, how to shop, etc. Making sure she was nutritionally replete, just very important in the underlying design, making it doable. She responded quite well to our protocol. And she was able to expand her diet. So we did the 8-week elimination. Her symptoms were greatly abated. And then we did challenges, and we were able to reintroduce many foods. So there was it was a period of time where we were able to increase with some foods, but we had to hold off on others. And then just slowly over the course of time, she was able to expand her diet to almost full. And she actually did the bulk of that work herself. She didn't need our guidance once she kind of got the lay of the land on how to challenge and pay attention, you know, and doing it one food at a time. Recently, she said she continues to do her best without sugar. So for her, the discovery wasn't that, you know, dairy or gluten were her top reactions, as is so often the case. For her, it's sugar. When she does have a mild reaction to gluten, but when she eats a high sugar food, she immediately starts to feel that early EOE symptom picture, which presents as heartburn and nausea for her. And then eventually she has this right-sided facial numbness or, you know, really profound dysphagia. Interesting paper. So just chasing down this idea that sugar was her #1 trigger. There's a report that adult EOE patients frequently develop IgE to sensitization to Candida. And this is probably because of the chronic exposure to corticosteroids. They didn't think that this was clinically relevant, but, you know, I suspect, so my working hypothesis for her is that, you know, sugar just stoked the Candida growth, and the Candida growth turned on IgE, and she was basically mounting an allergic reaction to IgE. She continues to do well. She's on a basic protocol with us, continuing with sublingual immunotherapy, which we recommend you do, you know, 3 to 5 years, uses quercetin D probiotics, is on a very full diet, but low sugar and gluten-free, able to consume a lot of her formerly antigenic foods, but likely consuming some food groups that are causing some symptoms. Okay, so she's got some background symptoms that she reports in that final bullet. I have to be honest and say I don't know what they are. They're not significant enough where she's talked to me about them. All right, here's another challenging case. This is a 63-year-old female with polymyalgia rheumatica and eczema. Lucy came to me with a diagnosis of polymyalgia rheumatica. That was the big deal. She also happened to have really pretty terrible hand eczema as well, a lifetime of hand eczema. But she was in so much pain from the PMR. That was where we put our focus. Onset was 1.5 years ago, really right around the time she retired. Difficulty with activities of daily living, just felt really old and miserable. Oral steroids, which are usually very effective in PMR, were only helpful for her short term. Low-dose naltrexone, Plaquenil, both were not helpful for her. And again, as I said, she had lifetime severe atopic dermatitis, specifically hand eczema. Used topical steroids chronically. She had trachonicia, so that's 20-nail dystrophy, and you've seen it before in practice. Sometimes you'll actually see the nail change before you'll see the hand change. In psoriasis, you might see trachonicia or those pinprick lesions on nails, and you know that can precede the onset of psoriatic arthritis. So it just gives, I think in this case, it just provides insight to the extent of the issue with her, that it was deep and long lasting, and something we can also pay attention to. So trachea, nails grow out in a healthy individual in about 6 months time, and we can track turnaround by paying attention to nails. This is a challenging condition though, and I wouldn't necessarily have high hopes of shifting things around, but we worked with her because she was self-conscious, and it was one of the goals she had. So for PMR, what we did, again, a basic protocol, as you've already heard me mention many times in this deck already. We did a standard IFM elimination. We did it for 6 weeks. I used a medical food for her, an anti-inflammatory autoimmune GI medical food. So gut permeability plus some anti-inflammatory interventions and a little bit of extra protein. Probiotic and antimicrobial botanical combination. I did some stool test, a stool study on her, and these interventions were based on that. A good amount of EPA, DHA, some GLA, vitamin A, vitamin D, DHEA, minerals, some B vitamins, and then we moved through various anti-inflammatory botanical and enzyme combinations. Honestly, we didn't do, I didn't get a lot of benefit with the interventions with her PMR, at least not initially. It wasn't until the very end of her time on the intensive, as well as the protocol, that her pain resolved. It was as if a light switch kind of shut things off. It was challenging, actually. So she needed a lot of support from my team. My team was a lot smaller back then. But it's essential that the people who are managing our practice, understand this journey. Ideally, most of the folks working here have gone through elimination, have done these kind of interventions before on themselves, and they can support our patients through with a certain kind of sensitivity that we don't encounter in other practices. So in this case, my team really helped her hang in there because she wasn't responding to our protocol initially. But then she did, and really that's the end of the PMR. In fact, I've just heard from her maybe 2 weeks ago, saying that she's just doing fabulously. Temporary improvement she reported with the dermatitis, but then it came back, and she didn't attribute it to our interventions. She just has a lifelong relapsing remitting pattern, and probably that's more correlative to the steroid use. So at this time, I went aggressive with an inside-out approach. Turned up the volume on these nutrients, GLA, A, D, zinc, and omega-3s. And she stopped her cortisone cream. She actually stopped it without a taper, which I would never, ever recommend doing. So we turned up the volume on the nutrients. She stopped her cortisone cream. And this is a photograph of her hand. She said the itching is horrendous. It's very uncomfortable. There's swelling. She can't get her ring off. She said it's not working. She's following the treatment plan verbatim, and it's not working. She's going to see the rheumatologist in a week. The rheumatologist did not appreciate the intervention that I did for her PMR, even though it resolved it. And he thought she looked unhealthy. She actually looked really well. She lost a little bit of weight, and just, her skin was glowing except for her hands. But he was recommending methotrexate for her eczema. And she was miserable enough where she wanted to start the methotrexate, and I felt horrible. It was a complete fail for me. And I needed to do some digging. First of all, she was experiencing just horrible rebound dermatitis due to steroids. Steroids thin the barrier and allow the exposure to, antigens profoundly. So that's one thing. If your patients are on steroids, you just have to initiate concurrent to a good protocol, a very, very slow taper. So patient 1, the first eczema patient I presented to you, was an inside-out approach. And now we're going to an outside-in approach. Filaggrin might be a protein that you've heard of. It's a major player in the epidermis. It's a barrier protein, and as it breaks down, it forms something called natural moisturizing factor as well. There are many mutations. 14 are very common. 10% of Europeans have a filaggrin mutation. It's interesting. This one of the theories around that is that it could be a passive route for like a natural vaccine to have this barrier issue exposed to more microbes. The other consideration has been it might increase the ability to make vitamin D. So in the dark northern climate, you know, those with barrier permeability perhaps survived. I don't know, it's speculative, but regardless, it's extremely common. And a null mutation is a very strong risk factor for severe atopic dermatitis and especially hand eczema. Filaggrin has been associated with the atopic march across the board. You can test for filaggrin. In fact, I've tested myself. I have chronic mild ichthyosis vulgaris, just dry skin, and I'm heterozygous. However, in my family, my sister has dyshydrotic eczema. I haven't tested her, but I would not be surprised if she had more than one mutation. So profilaggrin here is in the granular layer. It's broken down. So the profilaggrin chain is broken down by proteases, and then the filaggrin itself migrates up to the cornified layer where it complexes with keratin and just forms a impressively impenetrable barrier. It keeps water in, keeps allergens, toxins, UV out. And then the filaggrin and keratin break down additionally after they're spent, and those compounds migrate up to the very surface there and form the natural moisturizing factor barrier at the top. So just a very, very impressive system. But you can imagine having filaggrin mutations could wreak some serious havoc with regard to the barrier. There's lots of research out there on filaggrin mutations and the atopic march in general, not just atopic dermatitis. Ceramides. So ceramides are right in the mix there with filaggrin, with keratin, with natural moisturizing factor. They're big players in the lipid layer, about 50%. The ceramides are branched chain fatty acids that are as important as filaggrin and keratin. They keep water in, minimize solute loss and prevent, that antigens from getting in as a part of the whole system. Diminished ceramides in the epidermis have been associated with psoriasis and atopic dermatitis. As you probably know, ceramide topicals are available now, and there are some prescribed, some higher dose ceramide prescriptions that we're using in practice that are very helpful. Interestingly, the study just came out January 2021, showing filaggrin mutations result in ready uptake of common chemicals. In this population, we need to be advising clean skin products. So for Lucy, I'm turning my attention to really tending outside in. This is her protocol. We do bleach hand soaks. I do a ceramide prescription, and then I actually had her do a ceramide probiotic wrap at night. I was experimenting at this point. Had her just mix it together and, put gloves on over her hands and do a micro taper for the steroids. She needed to get off the steroids, but we definitely didn't want the rebound dermatitis potential. Bleach baths, there's mixed research on it. So this study says they're not more effective than water baths alone, yet this study suggests that they in fact are. My experience clinically, actually our collective experience here, I talked to a handful of folks here, is that bleach baths absolutely work. In fact, I would say that any patient I'm able to convince to consider doing it has had a favorable outcome. For Lucy, she only needed to do them in her hands, on her hands, and so she didn't have to get in a full tub of bleach. But it's straightforward. It's not. It's just a micro amount of bleach. We've got a great ceramide cream that we've given to IFM to use in the toolkit. The ceramide prescription is very hypoallergenic and well tolerated by most, but there are a couple of sensitive individuals who have had reactions to even the most hypoallergenic product. And for those folks, we created this cream. Actually, my nutrition director, Emily Hodges, created this cream, and instructions are there for you if you would like to do it. Here she is. Here are her hands. They're better. And they continue to be better. As I said, I've just heard from her recently. And I just want to highlight here in her second sentence that her fingernails turned around as well. So not a common experience, but it did happen in this case. Considerations for the severely allergic patient. The patient is your guide in this case. They're going to know their reactions. I'm thinking of a patient who came to my practice who put his coat down on the chair before he sat down because he was clear that he would react to the foam underneath the upholstery of my chair and develop hives. He had done it many times and knew his own drill. So patients are our guides in this case. Think about permeability as a major antecedent. Think about dysbiosis. Anything that you prescribe, you'll need to be doing some research on purity. I have the patient do it themselves. They can work with maybe our front office if they need extra help. But you need to do a drill down. They tend to need to do a drill down into the product. So for instance, some probiotics use soy as a substrate, and you may need to compound or customize. Again, look for cross reactions. As I mentioned in the lab lecture, you can test for some of those. Your interventions, you should start low and slow. Sublingual immunotherapy might be appropriate. Administer, in a safe environment, or have an allergist start. Low-dose allergen therapy is an option, LDA. There's not a lot of research on it, but it can be helpful. It's an alternative. It's a lower dose alternative to sublingual immunotherapy. Considerations, detox fasting, topical nutrients as tolerated, energy medicine can be helpful, autonomic nervous system rebalancing, de-stress, and then of course co-manage the severely allergic patient as needed. So remember the 6 R's for allergy. I think it's helpful. Again, with our allergy patients, we have to palliate first. And then just move through the rest. I think you'll get good results. You'll be pleasantly surprised. The remainder of my decks will cover what we're doing in our clinical practice. Thank you.